and welcome back to the channel. If you are new here, then hi, my name is Brittany and I'm a nurse practitioner. I am also the creator of the Brittany Holzbeck NP Review. It is the most comprehensive and affordable nurse practitioner boards review on the market, and we've just had some big changes, so the entire course has been updated as of December 2024. So all of the new information includes lots of memory tricks, lots of graphics, and should reflect everything that you would see on your AANP or ANCC boards exam. It is also accredited by the AANP, so if you complete the course, you are eligible to collect 15 continuing education credits. The entire course can be found at www.thenewnp.com. I'll make sure to have the website up here on the screen. Also, everything will be linked in the description box below. Also, if you have any questions for me, do not hesitate to leave a question in the comments, or you can actually email me directly at npreview@thenewnp.com. And again, that will also be here on the screen and linked in the description box below. Today's video is an excerpt taken directly from my complete review course. If you would like to hear the full lecture, then make sure that you head on over to thenewnp.com. In this lecture, I answer a question that I have got asked by many. And so the question is, what exactly does the boards use in regards to treatment of asthma? Do they use the updated GINA guidelines, or are they still using the SABA first, the short-acting beta agonist first? And so I went to my Instagram. I asked, did your test use the updated GINA guidelines, or did your test use the SABA guidelines? And in this lecture, I give you the answers that I found. This time, we are going to be talking all about the respiratory system. First up, asthma. So asthma is characterized by bronchial hyperresponsiveness, chronic airway inflammation, and the tendency for a person's airway to constrict in response to various triggers. So for example, mold, furry animals, pollens, those can all be triggers. In addition to these triggers, asthma symptoms can be triggered by exercise as well. Exercise trigger asthma symptoms generally develop 5 to 15 minutes after a brief episode of exertion, or about 15 minutes into prolonged exercise, and it generally resolves with rest over about 30 to 60 minutes. Asthma can develop at any age, but it is a common disease in childhood. Many children will experience a remission of their symptoms around the time of puberty. However, there is a potential for reoccurrence years later on in their life. So symptoms of asthma include dyspnea, cough that's often worse at night, chest tightness, wheezing, and this signifies narrowing of the airways. Physical findings that would suggest severe airflow obstruction includes tachypnea, tachycardia, prolonged expiratory phase, poor air movement, or even something referred to as a quiet chest, and then tripod breathing. When it comes to diagnosing asthma in the adolescent to adult, we use spirometry. That is the preferred method. So what spirometry does is it measures a person's forced expiratory volume and their forced vital capacity. A reduced FEV1 FVC ratio of less than 0.7 indicates an airflow obstruction, and this is definitely an important number to remember. So spirometry, it should be performed before and after a bronchodilator, and this is to determine reversibility of airway obstruction, because reversibility is an indicator that the patient does in fact have asthma. So specifically, an increase of an FEV1 or FVC of more than 10% after administering a bronchodilator is considered significant, and it's highly suggestive of an asthma diagnosis. And this is another important number I would say to remember as well. A reduced FEV1 FVC ratio of less than 0.7 indicates airflow obstruction, and an increase of the FEV1 or FVC of more than 10% after a bronchodilator is indicative of an asthma diagnosis. It's kind of silly, but I did have a memory trick here that can help you remember these numbers. It's just remembering the time 7:10 a.m. when it comes to asthma. The 7 represents the less than 0.7 for airflow obstruction. The 10 is for the greater than 10% indicates reversibility. AM is for after medication or that bronchodilator. So if it helps you, it's there. All right, so let's talk about how we manage our patients with asthma. So managing these patients is a continuous process that involves assessing them at each visit and then adjusting their treatment as needed and reviewing their response to the treatment. It's important to understand that patients that have asthma, they're divided into steps based on the severity of their disease, and then their treatment plan is going to be tailored to this. So step 1 is patients that have asthma symptoms that occur less than 2 times a week, and also these patients wake up to symptoms less than 2 times per month. So in step 1, remember, it's less than 2. Daily symptoms less than twice a week, and nightly symptoms less than twice a month. Also, patients in this step have a normal FEV1 and no more than 1 exacerbation per year. Step 2 defines patients that have asthma symptoms 3 to 6 days a week. Also, nighttime symptoms 2 to 4 days a month, and 2 or more exacerbations per year. So remember, step 2 is symptoms more than 2 days a week, but not every day, 2 to 4 nighttime wakings, and more than 2 exacerbations per year. Step 3 is when the patient experiences daily symptoms of their asthma, nighttime wakings at least once a week, and then an FEV1 between 60 and 80%. And then finally, step 4, these patients wake up nightly due to their symptoms. They have severe limitation, and an airway obstruction is indicated because they have an FEV1 less than 60%. All right, so that's how we classify our patients with asthma. This next slide will go over how we choose then their treatment. So for a long time, a short-acting beta agonist inhaler, a SABA, was used for rescue therapy. However, the Global Initiative for Asthma, or GINA, they recommend that this is not sufficient treatment and that there's strong evidence supporting the use of inhaled corticosteroids for both rescue and maintenance therapy. And this is because this helps with the goal to protect them from having severe exacerbation of their asthma symptoms. So really it's trying to treat the underlying inflammation that we also have with asthma. GINA also states that the frequent use of a SABA inhaler actually increases the risk for exacerbations. And this is a quote taken directly from the GINA's website. It's public information. If you've never visited their website, I do recommend that you check it out. But I'll read this quote here. It says, "Many guidelines recommend that patients with mild asthma should be treated with as-needed SABA reliever alone, but this dates back more than 50 years to when asthma was thought of primarily a disease of bronchoconstriction. However, airway inflammation is found in most patients with asthma, even in those with intermittent or infrequent symptoms. And although SABA does provide quick relief of symptoms, SABA-only treatment is associated with an increased risk of exacerbations and lower lung function." So these GINA guidelines, they've proven to be effective. The reality is, though, that your board's exam actually could use these guidelines, the GINA guidelines, or the original SABA first guidelines. And I know this because I actually did a survey with a lot of individuals that just took the exam, and I got almost a 50-50 response as far as what was on their exam. Was it SABA first, or was it following the GINA guidelines with the corticosteroids? Fortunately, they're not going to use both. So if you get an asthma treatment question, they're only going to use one of the guidelines for the correct answer. So you're not going to see, Symbicort and albuterol in there as rescue options, and you have to pick between the two. It's going to be one or the other. I thought that was kind of bizarre when I asked, but that is the answer I got. It was like a 50-50 response 50% said they got questions that used SABA as first line. 50% said they got questions that had a corticosteroid included in their first step of asthma therapy. And that was in both AANP and ANCC. So just know when you go to take your test, you could see either one, but you won't see both. So, for example, if a patient that belongs to step 1 in the asthma staging, the answer for treatment could either be PRN, so as needed, low dose inhaled corticosteroid with formoterol, and that's the GINA guidelines, or it could be a PRN SABA such as albuterol. They're not going to have both, though, as possible answers in the same question. All right, and so I'm going to read through the various treatment options here that are on the slide based on the patient's severity of asthma. When you look at this, each step, option 1 that's listed, because there's option 1, option 2, each step under option 1 is the GINA guidelines. So for patients in step 1, there are 3 options. The first option listed is what GINA recommends. It includes, like I said, a PRN low dose inhaled corticosteroid with formoterol. Other options include a PRN low dose inhaled corticosteroid with a SABA or a PRN SABA only. Briefly, I want to define the mechanism of action for the beta-2 agonists because they are such a useful tool. So beta agonists, they work by engaging the beta-2 adrenergic receptors on smooth muscle of the bronchial tissue, thereby relieving bronchospasm and reducing airway resistance. And then in regards to the GINA recommendation, those inhaled corticosteroids combined with a long-acting beta agonist, the formoterol, that's a long-acting. Formoterol, it's important to be familiar with because it's actually, yes, it's a long-acting beta agonist, but it has rapid onset. So it's such a cool medication because it actually can provide bronchodilation within 3 minutes, but it's long-lasting. So it has like both the best of both worlds. It is important to know, though, with formoterol, it can only be used in combination with an inhaled corticosteroid. It's contraindicated to use as monotherapy. Like how we can do the short-acting beta agonist as monotherapy, you cannot with that long-acting beta agonist. So step 2, it has 2 options listed. The first option, this again is a PRN low-dose inhaled corticosteroid with formoterol. The alternative options are going to be a maintenance with either daily or twice a day low-dose inhaled corticosteroid plus reliever therapy with either a PRN SABA or a PRN inhaled corticosteroid with a short-acting beta agonist. Step 3, there's 3 options listed. The first option includes maintenance and reliever therapy with the low-dose inhaled corticosteroid formoterol. The second alternative option is maintenance therapy with a low-dose inhaled corticosteroid with a long-acting beta agonist, plus reliever therapy with either a PRN inhaled corticosteroid with a SABA or a PRN SABA alone. The other alternative treatment option for step 3 is maintenance therapy with a low-dose inhaled corticosteroid plus a LAMA, so that's a long-acting muscarinic agent, or a leukotriene receptor agonist, plus reliever therapy with either a PRN inhaled corticosteroid with a SABA or a PRN SABA alone. And then step 4 has 3 options as well. The first option, again, that's GINA's recommendation. It's maintenance and reliever therapy now with medium dose inhaled corticosteroid formoterol. So they've titrated up those inhaled corticosteroids. The second option is maintenance therapy with a medium dose inhaled corticosteroid with a LABA plus reliever therapy with either, again, the PRN inhaled corticosteroid with a SABA or a PRN SABA. And then the final option there would be maintenance therapy with a medium dose inhaled corticosteroid with a long-acting muscarinic agent or those leukotriene receptor agonists. Plus, then, of course, we always have our reliever therapy with every stage. So either a PRN inhaled corticosteroid with a SABA or a PRN SABA. And so those are the treatment options. I definitely do recommend that you review them because you will likely see a question on how to treat our asthma patients. I have a couple of little memory tricks on here. The GINA, honestly, I found the GINA very, very easy to remember because it's that step 1, step 2, step 3. We're always looking at this low dose inhaled corticosteroid with formoterol. Step 1 and step 2, it's still an as needed treatment. Step 3, we're just using it as a maintenance and reliever therapy. So the other alternative, I have the quote, and this was back from my YouTube days, if you've been here that long. There's the phrase, SABA is life, man. And so that just helps you to remember how the treatment options are stepped up based on severity. 1 is a SABA. 2 is an inhaled corticosteroid, that's the IS. 3 is a low dose inhaled corticosteroid with a LABA, long-acting beta agonist, that's the LIFE. And then 4, it's a medium dose inhaled corticosteroid because we're titrating up on those steroids. So SABA is life, man. That stands for SABA, then inhaled corticosteroid, then long-acting beta agonist, and then we do the medium dose inhaled corticosteroid. So it's going to be one of those two. GINA is obviously much more easy to remember. Although if you remember that SABA is life, man, you'll remember with each stage what you are adding on to their treatment, and I think you will be just fine. Alright, well, hopefully you enjoyed the video. Remember, that was just an excerpt from the complete lecture. If you want to hear the total lecture and complete the review course, then head on over to www.thenewNP.com. Again, everything will be linked in the description box below. As always, I wish you guys nothing but the best. Don't forget to learn something new every day, and we'll talk soon. Bye, guys.
Living life, every day, late at night, not okay. All I want, and I pray, all I need are some better days.